I believe this video will be extremely helpful for anyone who's just newly qualified and will be starting work in a place like the ED or ICU or anywhere similar in the hospital, or for any internationally trained nurse who trained in a foreign country and is in the process of coming to work in the UK, and you'll be working in the UK hospital, whether in the ED, ICU or wherever. Or for anybody who has been in the UK for a while but has been working in, let's say, a nursing home or a care home and is thinking or contemplating or moving to the hospital setting. And let's say you haven't worked in a hospital before, or you haven't worked in a hospital in a very long time. I believe this video will be extremely helpful. This video is going to show you some of the mistakes or errors that I did that were really embarrassing in my first 1 month of being in the ED as a nurse, and then there are definitely lessons that you can learn from them. So if you're interested, stay tuned. So first of all, let me explain my situation to you for those of you who are only seeing me for the very first time. So I moved to the UK from my home country, Ghana, almost immediately after nursing school. Almost immediately. I had just 1 year of rotation or 1 year post-school experience, and then let's say about a month or two in a private hospital or a private clinic, I should say, and then I moved to the UK. And when I moved to the UK, I have always been working in a nursing home. So the only nursing experience I had was in a nursing home, very different from what happens in the hospital. And I stayed in the nursing home for over 5 years until just recently when I moved to no other place than the ED. So anytime I had very uncomfortable or unpleasant situations where I embarrassed myself, situations where I felt very stupid, situations where I felt like the earth should just open and then swallow me, situations where I felt like God should just come and then the whole thing would just go away, everybody would forget, situations where I came home crying to my husband, I wrote these things down. One, to reflect on them. I'm gonna need it for, let's say, when I'm doing my revalidation, and two, to educate other people. Before I go ahead, let me also say that because I had some form of nursing experience in the UK and I was not new from OSCE, the hospital that I'm working for, they only gave me 4 weeks of induction. And if you remember from previous videos, I will link them here, I did mention that I'm only contracted for 30 hours a week. So this 4 weeks was 30 hours a week for 4 weeks. So that is 2 long shifts and then 1 half day. And there's long shifts as well. One is a weekend night because of my husband's rota and because we have childcare issues. And you know that most of the time there's a lot to learn during the day. So in actual sense, I had, let's say, about 2 shifts each week for my induction period. And let me also add that these were weeks where I was still doing courses or trainings. I had so many trainings to be done. You know, they need you to train and get access so that you can do several things on your own, right? So I was still doing training. So there wasn't much induction, I should say. But for people who are just recently qualified or just from OSCE, they do like sometimes 6 weeks. If I remember correctly, I said 6 weeks of induction, and usually, you know, the contract is 37.5 hours, so they do have a lot of time to learn, if you get what I mean. Okay, so that is my situation. What I learned from this whole induction period in the ED is, one, if I am ever to act as a preceptor to anybody, I have to be extremely patient with the person. I have learned not to judge anybody. This thing I'm telling you is a very serious matter. I've learned not to judge anybody and to be extremely patient with whoever I am teaching or whoever I am mentoring. And I would say the same for anybody watching me as well. Some of you have loads of years of experience and you're likely to be acting as a preceptor for newly hired people in your hospital. Please be patient with them. Please do not judge them. Please take your time. We all understand things differently, and we are all not coming from the same place. Education has been different, past experience different. So please be gentle, and I promise myself that I'll forever be gentle if I'm to act as a mentor to someone. Another thing that I realized is that all the nurses in the ED are brilliant. Everybody that I was ever paired with is exceptional, very intelligent. However, some of them are not so good with teaching. And I think the problem really is with that they are not going to say that because you are mentoring somebody this day, you are going to have less patients. You are still getting the same 5 patients or 6 patients or 2 patients that you get based on the unit you are. And then you are still expected to teach Nanelle, who's coming from the nursing home. So some people, they want to get their work done. They want to do it well. And they struggle to combine doing their nursing job very well and teaching you as well. Some of them were excellent. They were able to combine it and do it very well. Other people as well, it was a struggle, you know, and could see that there are some people that they didn't even talk to me much the entire shift until I would ask a question, like until I asked some things like they didn't know what to tell me or what to show me or whatever. So it was really difficult. So these were some of my embarrassing moments, and like I said, take your pen and take your paper and learn. So the first thing, I think I shared it in my first video to announce that I have left the care home, was ROC. So there was issue. This was resource. This was a place that is here in the ED, you know, resources like, let me say, where we put the most critically ill. And this person had intracranial hemorrhage and they needed to intubate the person and they needed something called rock. I was just there like that and I didn't know what rock was, and they was waiting for me, and then this was an emergency, you know, and I was just about now going to ask other people what rock was. The person who asked it did not know that I was new, so they expected me to like bring it, and I didn't know what is it honestly, until I went to one gentleman and then he said, oh, rock, it's in the fridge, and then he actually grabbed it for me. Thank God he grabbed it for me, because if he had asked me to go into the fridge, I may not have even known which one to pick, because there's so many medications in the fridge. So he picked it for me, and then just as I was leaving the medication room, the person came to grab it from my hand. It's like, you've delayed too much. The person did not say anything, but from the expression you could see they were not happy. So for those who don't know rock, I mean, based on the unit or the department you're working in your hospital, you might not come across it, but if you are interested in reading further, read or watch videos about rapid sequence intubation. It's a medication that is usually used by anesthetists when they're trying to intubate somebody. So there are several other medications similar to this, and then I think read about it. A popular YouTube video that I watched and that explained it to me very well, I will leave the link in the description as well. And then I would always say that the lesson you can take from this particular point or embarrassing moments of mine is that before you go somewhere, try and watch videos on YouTube about commonly used medications in there. For instance, there's a channel called Emergency Chaos. It has become I don't know the person who runs it. The person's face never even comes, but they talk about everything about the emergency department. Although it's a US channel, there's a lot to learn, even though I'm in the UK, right? So you can learn about commonly used medications in the ICU if you're going to the ICU. For those going to the ICU, the popular channel for this is ICU Advantage, okay? If you're going to the stroke ward, I'm sure you can Google or go on YouTube and search for commonly used medications on the stroke ward and learn about everything, the expected side effects, the complications, the contraindications, where it is stored, because some medications are stored in the fridge. You have to know all of this so that when you're asked, you have a bit of an idea. I was clueless and I felt so stupid. So that is lesson number one. Before you move to any particular department, read about commonly used medications over there, read about them, learn about them, and then, you know, have an idea on them. The second embarrassing thing that happened to me, if I can remember correctly, was the ECG. So back in the nursing home, we don't do any ECGs, or EKGs. We don't do that. And then I was actually seeing the thing for the very first time. In Ghana, nurses don't do ECG or EKG, so I had no idea how to do it. Once again, I remember the very first one that I did, the doctor just quickly got up, right, and then went to the patient to say, do you have any chest problems? Have you ever been diagnosed of any? And the patient was like, no. They checked the person's vitals. The doctor was like, can you please do it again? And like the way the doctor said it and the way he acted made me feel like probably I didn't place the leads well, or probably it was just so confusing. Like I had not seen anybody being asked to do it again almost immediately in such a way, right? So I'm like, ish, maybe I didn't do it well. But that was my very first time I had done it. And to think that band 3s are doing ECG and they are not being asked to do it again, to think that people who have never been to nursing school are doing it so well, and I didn't even know how to place the lead. I was clueless. Once again, I went online, I went to YouTube and I watched how this was placed. I called a friend of mine, Joycel, who's been in the ED for so long, and then she explained in my Ghanaian language how it is done. And today, let's forget about the V2 and go to V4. V4, then you see the mid axillary. So thank you so much, Joyce, and thank you so much, Nanaba, and thank you so much, Danny. You guys have been amazing. I keep calling these friends of mine who are in these units already, and I've been working there for years to help me whenever I get confused about something. So I watched several YouTube videos. I watched how it is placed on a man. I watched how it is placed on a woman. You know, sometimes women with the breast, it gets in the way. So I watched all of this to master how it is done, and then how to interpret it as well. Although I'm not expected to know how to interpret it as a nurse in the UK, I have learnt it even ahead of time. So when I see, let's say, the very common ones that could be dangerous, I know that this is an emergency. Like I know how to recognize a V tag, a V fib. I know how to identify, obviously, asysto, and the very, very common ones, I'll leave some of them on the screen and then their names as well so you can know. So the lesson you can learn from this is that search online for commonly done procedures in the units that you're going to. Let's say you're going to the stroke ward, and let's say you'll be asked to provide oral care for people that are not unable to do that. Learn how to do it. Watch YouTube videos on how to do it the proper way. If it's the ICU that you're going, what procedures are done over there? Maybe head to toe assessments, ABCD every time. Check how to do it. Learn it. Let it be a part of you, like you can recall it even from your sleep. Okay. The third thing was the cannula. You know, is it the Tegaderm or the wee plaster that they put on the hand after you've inserted the cannula? The way we insert cannulas in Ghana is totally different. Although I did my venipuncture and cannulation training, obviously you always know that training is not the same as when you're on the field. I mean, how many people have done CPR training and have never even used it, right? So this is what happened. Somebody came that time, I was in triage, and then I started the line, and guess where I put the plaster? I turned it transparent part, which is supposed to be facing up, facing where the cannula is facing. I brought it down. As stupid stupid as I was, I brought it down. See, sometimes it's not like you are stupid, but in that particular moment, you are just not thinking right. You're just so confused. You don't want to make so many errors. You end up even making worse and more stupid errors. That was me. What on earth was I thinking when I put the thing upside down? And the nurse saw it and you could see she was like, "Hey, that's stupid." She didn't say, but like. So obviously, if you are in a nursing home for over 5 years of my life, I never inserted a cannula. Never. The most I did was draw blood for investigations, which was usually what 9 staff would do. So I obviously was still doing that. Thank God, at least I was doing that. On this note, what I would say is that even if you're in a care home, try as much as possible. Maybe because of your family circumstances, financial issues, you cannot go to the NHS at the moment for the experience and for the skills. I would say that when it comes to picking overtime shifts, try as much as possible to register with an agency that will let you pick shifts from the hospital so you can learn. That will be extremely useful to you. That will be extremely useful, I'm telling you. So for those of you who are wondering, in the UK, when you insert a cannula, you would put the tegaderm, if that's how they call it, and then there's a transparent sort of like plaster. So it helps you to monitor possible complications with cannulation or venipuncture, like let's say infiltration or phlebitis or whatever complication it is. Because it's transparent, it enables you to assess the cannula site easily, without having to take it off or anything. So they want to monitor or check where the fluid is going, the direction of the fluid. So that is why it is placed there and it's a transparent sort of like plaster. I would say that if you're moving to the hospital, obviously you need to be abreast yourself with cannulation, venipuncture, especially in the AD, and then also the cannulas, the different colors, the different sizes, and possible complications with cannulation, and what you should do if you suspect, let's say, infiltration or you suspect phlebitis, or what to do. Like, how do you go about it? How do you even assess the site? What are you looking for? And all of that. Okay, so that's another lesson to be learned. The fourth thing, the error, is the VBG. This is the particular one that I felt like collapsing, or I felt like the earth should just open and swallow me up. When this particular thing happened, I wanted to cry. The nurse who was over there that day, who was my mentor that day, she said, "It's not a problem, don't worry, it's okay." But in my heart, I knew it was not okay. I knew it was not okay. I knew that I have been stupid. I knew that this was a mistake, but I felt so bad. In fact, even remembering it now, my morale has just gone down. So this is what happened. So there's so many devices in the hospital. Like, you guys, how do you even do it? Like, there's so many devices in the hospital. I mean, in the nursing home, if you have to check somebody's sugar or blood glucose, boom, boom, done, right? It reach, you're done. Blood pressure, pim, 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 boom. You reach, you're done. In the nursing home, we use the same blood pressure machine that is sold on Amazon, like the very common one that people have in their homes. That's what we use in the nursing home. Temperature, done. Push, done. Pulse oximeter, boom, done. In the hospital, everything is different. Everything is different. Even with the pulse oximeter, the people that we have to monitor their saturation continuously, especially the elderly, and it's not reading well, there's something where they can put on your forehead I had not seen it before. The BP machine, sometimes it will read and then it's just one number there. I'm looking for systolic and diastolic. Why do I have just maybe 128 over there? What does that even mean? Temperature device, different. Although the one that we use, I had used it in the OSCEs before, so I had seen it. So many different things. So one of the very different devices I had never seen before was the VBG device. So it's used to check venous blood gases. It's also used to check arterial blood gases, right? So how the device works is you take the sample and then there's a wee needle on it, and then it will aspirate some of the blood and then it will give you the results, right? But apparently it takes a while to print out the result. And then there are so many scans. Even before you check sugar on somebody in the hospital, you are scanning your barcode, you are scanning the patient's wristband, you are scanning so many things. It's just so confusing, and I was not used to that. So apparently you are going to scan 2 things on most of the devices. Most of them you need permission, or you need to show that you have been trained and you have a barcode for the duration of your validity as an operator. So let's say just yesterday I did my urinalysis and HCG, the cassette training, right? And apparently it's for 2 years. So if I get my barcode for the next 2 years, I can use it so my training expires and I have to renew my training, and then they'll give me another barcode. So guys, listen to this very carefully for those who are new to this whole system. Usually what I've realized is that most of these devices, you scan the operator barcode first. Most of them. Even if your eyes are bad and you're not reading, because it will show on the screen, scan operator ID. What did I do? So instead of scanning the operator ID, I went to scan my patient. And for some funny reason, it went through. Not knowing that, I also had to wait to see ready. I did see ready, but not knowing that the thing takes a while to process the result and then print out. Not knowing that somebody else had input their details, blah, 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 doctor has scanned their patient's barcode, had aspirated their patient's blood, and was waiting for the result. But because it takes a while, the person was not standing by the device. So when I went, I just saw the ready, and then I did mine. I scanned my patient instead of scanning myself, and the thing just printed the result. I'm like, but I've not even put the blood. How come it has a result for me? Guess what it did? It printed the result of the previous patient and used my patient's name. And do you know the sad thing? This is a very highly technology, high-tech hospital where after doing the urine analysis, after checking the person's BM, before you open the computer, it has already added it to the person's notes. It has already been recorded, has been sent to the doctor. The doctor can see it immediately. So that other patient's abnormal results was put on my patient's record. So now the doctors were now, so this is, let's say, severely respiratory acidosis. We have to do this. And it was not even that particular patient. It was for somebody else. So we now had to explain and error, and look at the mess. Because we used Epic. That's the software that we use. It's very, it's really like high class, if I should say. It's like, it's, in fact, like if you're giving medication and it's so close to the time, it would prompt you that, oh, are you sure you want to give this medication? This person received it less than 4 hours ago. If you're giving medication and let's say it needs a dual signature, it will prompt you, this one, you need a dual signature. If you have to do vital signs, it will show you. In fact, it's just, I've never seen anything like that before. It's like, wow. So guys, that day, I wanted the earth to just open up and swallow me so that everything will come to an end. Like, yes, everything should just come to an end because of that one error. That's how bad I felt. Another thing that I would say is another error that I did. You know, when I was doing my induction, I was so happy to help. And you are so eager to help that if you don't take care, you do so many mistakes. I'm just there. I want to do this. Have you watched that video? That funny clip where the medical student wanted to help so bad. He was just contaminating sterile fields. I'll insert the clip here if I see it. I'm sure that's how I was acting. So there was this doctor who was working, and the doctor needed me to hold a blood sample, but I heard him say sharps, not knowing that he was just trying to tell me that there's a needle, so be careful. So when I heard sharps, I thought he said I should put in the sharp box. So this person's blood, I went to discard it, and this was a patient that everybody had tried to take the sample. They were not get. And I just went to discard the sample after they had tried for so long. I just went to discard the sample because I had sharps. I thought he said I should put in this. I don't know that he said, like, as he's handing it over to me, I should be careful because it's a sharp object. Like, he finished what he was doing. He said, where's the sample? I said, what sample? It's in the bin. It's in the sharp box. At that point, I'm like, God, let me just go back to my care home. So this lesson is, listen carefully. If you're not sure, can you come again? What did you say? Do you want me to put it in the sharp box? What did you say? Did you say I should do this? Just be careful before you embarrass yourself. And there were 2 nurses there with the doctor at that time. Can you imagine how they looked at me? Very terrible, very bad. Another one, I was asked to send my patient for an x-ray, right? And this was a patient who had a fall. So we went to the x-ray department, and then they were like, you need to mention the name of this form, which I did not have. And then I also need to confirm that this patient is on a trauma bed or a trauma mattress. I'm like, no, he's not on a trauma mattress, and I don't have the form. So I went back to my unit to go and look for the form. A doctor was able to fill the form for me. And then I came back, and then I said, trauma mattress. Which one is trauma mattress? How come they didn't put the patient on the trauma? I didn't know what a trauma mattress was. Not knowing that the patient that I carried, I wheeled or I carried from the ED to the x-ray or wherever department, was already on a trauma bed. But I did not even know what a trauma bed was, so I could not even tell them. When I came, they had finished doing the x-ray because they realized it was a trauma bed or trauma mattress, and I was now going to look for a trauma mattress when he was already on one. I didn't know what it was, so I went back to my preceptor. I asked, which one is a trauma mattress? Then he showed me. I said, but that's what he's on. I went back, they didn't finish the x-ray. I'm sure they're like, what a stupidness. You're going all over looking for trauma mattress when he's already on one. The next one will be the given set, right? So the given set, I knew the flow one, right? And then I knew the one that you put in the pump, right? The pump infusions, right? The given sets for the pumps, the one that has the blue and the orange thing there. But what I did not remember was the color at the back. So me, I have a patient, they said I should infuse. Now I am good at regulating the pump. I went to take the given sets, I've inserted it in there, not knowing that I have picked a given set for blood transfusion. Some of these errors, I know I'll never make them again because now I know. But imagine how I feel when I make them. They said I should take blood cultures. I've set up my tray. My sharp box is here. My tourniquet is here. My alcohol wipes. My butterfly needle. Everything on set. I'm going to pick my blood culture bottles, all of them. Not knowing I picked the yellow one, which is for pedics as well. The nurse laughed. She didn't want to laugh. And she's one of the nicest nurses, but she laughed. And I caught her. Then she said, no, Nanelle, that's for pedics. I said, oh. I dropped it. This world is not my home. I'm just passing through. The ED is not my home. I'm just passing through. My treasures are laid up somewhere in the care home. Hey. So far, these are the ones that I was able to write down, right? I would say that if you're going to work in the AD, there are some topics that you should read. Read sepsis, read DKA, read diabetic management, read about the cardiovascular conditions, read about ABCD assessment, read about medications and infusions. And then even with vital signs, I know you always just check vitals, but even with vital signs, know when not to do what with the figures you're seeing on your screen. So let me give you a typical example. See, sometimes I'm not stupid though. To me, I feel like I'm okay, right? But I nearly did something stupid. For instance, I went to check a patient's vitals. I checked temperature. It's fine. I've checked this, I've checked that, I've checked that. And the blood pressure was like 214 over, let's say, 110. And I recorded vital signs, everything. The software that we use, Epic, it has notified me that this is a very abnormal because it goes red. So I know that it's abnormal. I've written it down that I would inform the doctor, blah, blah, blah. Then I went to medication, right? I went to medication and guess what? I realized that this patient has BP medication. So I'm in a hurry to give this person's BP medication. And then as part of the medication that were due, I saw normal saline infusion. I mean, sodium chloride, 0.9% infusion, 1000 mils. And look at me, stupid self. I went to grab the infusion. I went to grab a given set. I'm looking for pump, going to set it up. I'm giving the infusion. I've given the oral medication. I've scanned my patients. I've checked everything. I've given my medication. I'm about to set it. But you know that you need to cross-check your IVs. In my hospital, you cross-check all IVs, including IV paracetamol, including normal saline. You have to cross-check with another person for dual signature. And I went to check with this person, and this person is like, it's too early for infusions. What's the blood pressure? I'm like, never mind, thank you. Then I went to my patients. I said, you know what? Let's see. I'll come check your blood pressure again in a few minutes. You have infusions, but I'm not happy to give it to you because your blood pressure is already too high. So let's see. I'll tell the doctors about it. The doctors came for ward rounds some few minutes afterwards. So I documented that I'm not going to give because this, that. And the doctors came some few minutes afterwards, and I'm like, doc, I see you prescribe a 0.9 sodium chloride infusion, 1000 mils. However, I wasn't comfortable administering it because the blood pressure, as if I thought of it from the beginning, because the blood pressure is quite, yes, I'm going to cancel that order in some few minutes. Yes, I noticed. I just rechecked the blood pressure again and it's really high. So I'm going to prescribe a GTM patch and what, and that. I'm like, God, thank you. See, be so in sync with what is going on. Don't just think it's an order, I need to do it. It's an order, I need to do it. Like, think, because there are newly qualified doctors who are there. Sometimes they get confused. Think, because you are responsible for your actions as a nurse and your inactions. You should know. Why are you giving the person more fluids if the person is already severely hypertensive? Why are you pushing more fluids? Think. You checked the temperature, right? You realize that, let's say, it's very high and this person has not been prescribed any antipyretic. Why are you delaying when you know the dangers of severely high temperature? Why are you not going to get somebody to prescribe, let's say, IV paracetamol if the person is already on one? Why are you doing personal care of your third patient when somebody's temperature is 39.1? I have learned that in the ED, you need to learn how to prioritize and then know what every result that you get from any check shows what you can do and what you cannot do. And you have to be in tune with what you're doing. If you're abstract minded and you're just going according to the order, the software says the person is due for paracetamol, so you're giving paracetamol. The software says the person is due for insulin, so you're giving insulin. The software says the person is due for this. But go back to your checks and see, is the person really okay to take this? The person is due for all his BP medication. Let's say BP medication, maybe about 6 different BP medication, beta blockers, calcium channel blockers and all of that. And then you check the person's blood pressure. Systolic is 90. It's already low, but you've gone to give all these 6 tablets to the person again just because it's due. We need to think. In a nursing home, we don't even check vitals before we give medication, except it's digoxin. I don't know how people say digoxin, except it's that where you're checking the pulse. Aside that, we hardly check blood pressure before we give all these things. So my mind was just, see, let this guide you to be in tune with what you're doing, to be very extremely observant. If you're tired, do not go to work. And it's always good to cross-check. Always good to cross-check with someone and don't get offended. Like these mistakes, I'm happy I made them because now I'll be so careful, extremely careful in my practice now that I'm on my own. And if you ask me how it's going, it's not going so well, but I'm determined. I'm learning so hard. I'm going to the libraries. I'm reading about what I'm even supposed to know. And I'm just going over. And honestly, it's getting way better. It's getting much better, but I realize there's still a lot to learn. If you learned anything from this video, let me know. What was your most embarrassing moment in your induction period? What would you say? And please, let's be kind to people who are just starting at our workplaces. Thank you so much. Bye.